Hi, good evening, everybody. Good afternoon, or maybe good morning. It is my great pleasure to welcome all of you to this very special IACH webinar or web conference, if you prefer, entitled Alkylating Agents, Old Dogs with New Tricks. I'm Mohamad Mohty from the Sorbonne University and the Saint-Antoine Hospital in Paris, and I'll be moderating this very exciting webinar. These are my disclosures. This activity is supported in part by MEDAC, but this is an independent medical education program, and no private entity interfered with the preparation of the slide, the choice of topics, or the content. So our focus for today is going to be around the role of alkylating agent in the allogenic stem cell transplant procedure or field. And I think we all know that this is a very complex procedure, and the final outcome of the patient will actually depend on several parameters. Obviously, patient characteristics, whether age, gender, CMV serostatus, comorbidities, is going to be very important. Will have an impact, let's say, for instance, on toxicity and non-relapse mortality. Disease status, but also disease type, will also play a major role. Being in a refractory situation is totally different from being in MRD negative situation, and this will obviously impact at some point the disease-free survival or progression-free survival, but also the relapse incidence. We're fortunate these days that we have different graft sources, peripheral blood stem cells, bone marrow, different donor types, whether HLA-matched sibling donors, matched unrelated donors, mismatch unrelated donors, but also the mismatch related donors, namely the haplodonors. And of course, we have the cord blood, and you can combine different sources in some protocols. We also know that the prophylaxis of GVHD remains a crucial step. But actually, in order to get all of this in, you need also the conditioning regimen. And the conditioning regimen remains the basis, the backbone for a successful transplant procedure. Of course, GVHD management, infectious disease or complications management, prevention of relapse, all of them are going, all of these parameters are going to play a major role. But actually, the conditioning regimen by itself is an important step. But also, as I mentioned, the GVHD prophylaxis regimen will play and will be a major role and will be impactful on the final outcome. And interestingly, some of the key advances we have seen in the last 10 years or so are actually related to the development of novel conditioning or preparative regimens, but also the introduction of post-transplant cyclophosphamide for GVHD prophylaxis. And this is why we thought this title about alkylating agents, old dogs with new tricks, is really attractive and clearly highlight how some alkylating agents, well-known, well-established, have tremendously transformed our field. When it comes to the conditioning regimen, I will not spend a lot of time highlighting that this has been a work in progress since the late 50s or 60s. The TBI, high-dose TBI conditioning. Then in the 80s, the BuCy, in general, busulfan-cyclophosphamide. And in the year 2000, we have moved almost in the majority of the patients towards the so-called reduced intensity conditioning or reduced toxicity conditioning regimens. In terms of GVHD prophylaxis, I believe that without any exaggeration, the introduction of post-transplant cyclophosphamide has been really a true advance, a true revolution. And we owe this to the pioneering work of the colleagues at the Johns Hopkins, who could show that by delivering a high dose of cyclophosphamide at days 3 and 4 after graft infusion is going to be a powerful tool towards controlling graft-versus-host disease or preventing graft-versus-host disease. And this proved to be effective in the haploidentical donor settings, but also you will see in other disease settings. So with this background, the scientific committee of the IACH designed this very attractive, very timely program. And you can see I'm very fortunate and honored to be joined today by a top faculty of expert, Professor Didier Blaise from the Institut Paoli-Calmette in Marseille in France, will give you a comprehensive view about the role of post-cyclophosphamide for GVHD prophylaxis. Then we will have Dr. Rémy Dulery from the Saint-Antoine Hospital in Paris, who will address the role of Thiotepa, which is, of course, an alkylating agent, based platform for refractory malignancies, because we are transplanting more and more refractory diseases. And last but not least, Professor Arnon Nagler from the Chaim Sheba Medical Center in Israel will give you an overview about the novel Treosulfan-based platform for conditioning regimen. And treosulfan has been, as we say, the new kid on the block, and it has been approved for conditioning prior to allotransplant. And the results generated from the registration trial, the phase 3 trial, you will hear about it, are quite amazing when it comes to its efficacy and safety. And of course, this is a live event, but also an interactive event, like all the IACH activities. So we would love to hear from you. We would like to have your questions, your comments, your suggestion. This is why we will dedicate ample time after the 3 talks for a round table discussion where we will address all of these topics. So for now, without any further delay, I would like to invite Professor Blaise, who will start by assessing or by discussing the role of post-transplant cyclophosphamide for GVHD prophylaxis. Didier, the floor is yours, and thank you for joining us tonight.
Thank you, Mohamad, and thank you, Arnon, for inviting me. Even if I wondered when I received the invitation, when you told about all dogs, if you were thinking about me, but I will try to show that I have still some new tricks sharing with you. So here are my disclosures. As has been said by Professor Mohty just before me, the Baltimore protocol originated in Baltimore at Johns Hopkins, and there has been a real breakthrough in transplantation, allowing to do some kind of easy haplotransplant as compared to what had been done previously. But the journey about the use of PTCY started many, many years ago, both in Baltimore, but also in Japan, or it has been shown that it was a very good drug to be used in this situation. It's, however, only at the beginning of this century that the Baltimore group defines that what was interesting in using cyclophosphamide post-transplantation was the dose. And clearly, they didn't achieve any good result with low-dose cyclophosphamide, but with a higher dose. As you know, the reason for that has been really very well explained by Leo Lusnik. When you give on day 3 and 4 high-dose cyclophosphamide, you will treat and you will make disappear the alloreactive T cells, and they are killed, while the hematopoietic stem cell transplantation or the non-alloreactive T cell are not harmed by this dose of chemotherapy and will repopulate the organisms they have been infused to, and will conduct to good hematopoietic and immunologic recovery. And Mohamad already shows this slide. The conditioning regimen and the transplant procedure is associate different aspects. For the dose of cyclophosphamide, 2 days, that seem to be better than 1 day, so a total of 100 milligram, associated with post-graft immunosuppression, an haplo donor, bone marrow infusion, and remember, and I'm sure you know that patient initially in this program and still done in the US and in Baltimore, they received bone marrow and a very highly immunosuppressive conditioning regimen based on TBI, fludarabine, and cyclophosphamide. So doing that, it's a mini haplo BMT as that has been defined and has been widely used in the US and in Europe. Why? Because it is very effective, and I will be very short on that. We know very well since the first papers that PTCY is effective to prevent acute GVHD for both grade 3 to 4 acute GVHD, but also grade 2 to 4 acute GVHD. Taking into account that this patient, the patients that have been transplanted are relatively old and they receive an haplo transplant. Also, the effect of PTCY seems not to be impacted by HLA mismatches, even if this is still debated and with some contradictory results, but at least it's now a clear-cut difference. Oh, I'm sorry. And also, it is also very active concerning extensive chronic GVHD. And I do think, and at least it was the case for me, that it was the first major effect I have seen using this regimen, because virtually in some situation you have no chronic GVHD, at least no severe GVHD, specifically if you use 2 doses of cyclophosphamide. So there are some complications with PTCY without any doubt. The first one is a CRS arriving after cell infusion. In fact, it's not with cyclophosphamide, it's rather the other way around, because when you do an haplo transplant, you have on day 1 and 2 and 3 some CRS, and when you administer the cyclophosphamide, you negativate this effect. And in our group, Benjamin Bouchacourt looked to this aspect, and clearly he showed that, in fact, when you have the grade 2 or more CRS, you have higher incidence of acute and chronic GVHD, leading to a worse GRFS in this situation. In fact, you have to keep in mind that the number of patients expressing a high-level CRS is quite limited, no more than 10 to 15%. So in the majority of the cases, it is not the case. The real complication associated with PTCY have been already reported. One is the cardiac toxicity due to the high level of chemotherapy you give, especially when you treat older patients. And Rémy Dulery very recently reported the effect of different parameters on early cardiac event. And as you can see here, the use of PTCY have a high action on the occurrence of the early cardiac event. But if you look to the outcome of the patient, you can see here that if the patient have received PTCY or no PTCY in this comparison, there is no impact of this cardiac event in the outcome of the patient, meaning that in fact you can very well manage this kind of complication if you are careful in the treatment, and also in older patients. Infection as a second parameter. It has been claimed initially that infection were a real problem in this situation of haplotransplant, and perhaps with cyclophosphamide. Early on, Roberto Crocchiolo, when he was working in Marseille, documented that you have a high incidence of viral infection during the first 3 months of transplantation. These have been also reported by Mohty, who showed that in fact you have a high incidence of bacterial, viral, and fungal infection in the situation of haplotransplant. But once again, when you look to the outcome, and especially for the viral infection, you can see that for all the patients that have been treated in this series, only one patient died from infection, meaning that this kind of complication can be managed, I won't say easily, but can be managed satisfactorily. With satisfaction. So overall, we know now very well that GVHD prophylaxis based on PTCY is very effective in haplotransplant. And as you know, from the early days of the mini haplo BMT program presented by the John Hopkins, many variations have been associated with this approach of non-T-cell depleted haplotransplant. And the variation included the use of different stem cell sources, PBSC, the fact that we treated many different categories of patients according to disease, lymphoid malignancies, myelodysplastic syndrome, acute lymphoblastic leukemia. The type of conditioning regimen, more intense than what have been initially reported in Baltimore, and with many differences. And in all these situations, as you can see here, there is a limited incidence of chronic and acute GVHD. In Marseille, Thomas Pagliardini looked at a series of patients treated both in fact at Institut Paoli Calmette and Humanitas that have received a haplotransplant after conditioning regimen associated fludarabine, busulfan, and Thiotepa. He analyzed a cohort of 100 patients with a median age of 58. Disease status for this patient were advanced for more than half of these patients. You can see that 60% of these patients have 3 or more comorbidities. Near 85% received PBSC, and 3/4 of these patients were treated with a RIC regimen, only 2 days of busulfan, and 1/4 with 4 days of busulfan. And looking to the result, as you can see here, the extensive form of acute and chronic GVHD were quite limited, with 7% and 40%, which is something very interesting and promising when you use even more intense conditioning regimen than the original FLU-TBI regimen. Now we are performing another analysis for patients who have been transplanted during an 8 years period. They all receive a first allo as first transplant with a haplodonor, receive PBSC. They all receive PTCY after transplantation. And in fact, we have 2 cohorts of patients. The one who received the standard the original flu-TBI, Cy-flu-TBI regimen, non-yellow ablative, and another cohort of patients who have received the TBF, according to what I have shown to you on the previous slides. Median age of this patient is a little bit higher, between 60 and 61. And you can see here that the proportion of patients above the age of 65 is 1/3 of the patient. As previously said, many of them have many comorbidities, and it's really related to the age of the patient we transplanted. It's mainly patients receiving transplantation for myeloid malignancies. You can see here that 20% of this patient was not in CR at time of transplantation. I will not go through all the details, but I wanted just to focus on the impact of PTCY in this situation. First thing we look at was the impact of age according to the different conditioning regimen. As you can see here, when you use a rigged TBF, you don't have any differences in the occurrence of GVHD, whatever the age of the patient. On the other hand, when you use a more less intense conditioning regimen, it seems that the older patient are doing a little bit worse than the other one. It is a retrospective study, so there are biases, notably the proportion of patients receiving flu-TBI are a little bit older than the other one. Now, and more interesting, I would say, is the prevalence of GVHD after transplantation and notably of immunosuppression. As you can see here, in both situations of non-myeloablative regimen or RIC regimen, it's a very little proportion of patients 12 months after transplantation are still with immunosuppression. And it is true for both conditioning regimen. So it means that, in fact, it indicates the depth of the efficiency of PTCY in this situation. Keep in mind that the patient have a median age of 60 years, and 20 years ago, we could not have dreamed of such result, notably in terms of GVHD prophylaxis. Non-myeloablative regimen also can be used in the haplo setting in very old patients. You know that the median age of the patient increased over years. And as you can see here in our series of patients we have analyzed in Marseille, and Sami Arbi did this analysis on 33 patients, different diagnoses. They all receive the fludarabine cyclophosphamide TBI. You can see that the incidence of severe GVHD for acute GVHD is 9%, and 36% for the patient needed some treatment for chronic GVHD. So it's a little bit higher of what I have shown to you previously, but it's really what I showed to you. Remember that I received the conditioning regimen with TBI, and I have indicated previously that it is this incidence of chronic GVHD increased with age. But overall, at the end of the day, you can see that in this cohort of patients, the incidence of non-relapse mortality is rather low, 15%, with a very good overall survival at 77% at 2 years. So this is very promising as results. Can one do better? And I know that one of the panelists will say, sure, we can do better. And I agree with him. First thing we could do is perhaps think about the PTCY modulation. Why to use 2 doses of 50 milligram? Originally, when they tried to do only 1 dose of 50 milligram in Baltimore, results were not so good. So the first thing we can think about is to change the timing. And some people, some investigators, give 1 day of rest between the 2 doses of PTCY. I have not seen the result published on this experience, but it's something we have to figure out. We could also use a lower dose. A lower dose, why? Because of the toxicities, the cardiac toxicity, which even if it's manageable, can be a problem, notably in older patients. And presently, we have we are putting together data on a retrospective study conducted in Saint-Antoine and Marseille, comparing cohort of patients receiving 100 milligrams or 80 milligrams. I have not all the results, but I can tell you that the incidence of GVHD is not higher than with 80 milligrams. Second thing, if you attend ASH or you are virtually or in presential, you could listen to this communication that show that look at the incidence of GVHD with different doses of PTCY, and I think it will be very interesting. The second possibility will be to use ATG with PTCY. As mentioned by Mohamad Mohty initially, in fact, we have two old compounds, cyclophosphamide and ATG. And they are the two drugs we have changed really the stage of transplantation. So the first thing you could consider, despite one have been reported initially by the Baltimore group telling that we should not use more immunosuppression prior to cyclophosphamide, is the use of ATG during the conditioning regimen. This has been conducted in Saint-Antoine with probably a lower extensive chronic GVHD incidence. So it is something of a high interest. The second possibility, as performed by our colleagues in China at the Ruijin Hospital, is to use a single dose of ATG on day 15 after transplantation or after ANC recovery. And they have already reported 23 patients with no grade 3 to 4 acute GVHD and a very limited incidence of chronic GVHD. They have now putting together more than 50 patients, and this will be soon published. And I think this kind of approach is also of high interest. Now, what about the non-haplo situation? Because it's working in haplo situation, as we have seen many examples. What about the other situation? One of the first experience that have been reported is the use PTCY of a single agent after HLA match transplant. And remember, in this experience, it's only bone marrow. And Kanakri reported the result of this trial and this experience just by looking to the proportion of patients who will receive additional immunosuppression in case of GVHD. And you can, in fact, these are the purple part of the bar, and you can see that the vast majority of patients do not need any more immunosuppression, or only one shot of immunosuppression. It is even more relevant in a match-related donor, and it's true the same way for different conditioning regimen, Bussai or Beflu. So in this situation, it's interesting, and now this is prospectively addressed also. Have we retrospective studies? Yes, the BMT conducted, in fact, two interesting retrospective studies. The first one compared nearly 1,500 patients who have received ATG with 170 patients who have received PTCY. It was here 1 AML and 10/10 MUD has been reported by Elia Brissot in 2020. You can see here there is no difference in terms of GRFS, no difference in terms of chronic GVHD, and the outcome seemed to be completely identical. Perhaps a trend for a better prevention of chronic GVHD. Now, if you look to the matched sibling donor, another report for the EBMT with nearly 2,000 patients receiving ATG and 200 PTCY, you can see there is no difference in terms of GRFS, but it seems that there is a higher incidence of chronic GVHD in this situation. And we have to keep that in mind at the present time. Another study has been conducted. It's a prospective study who, in fact, tried to find a good comparator to the standard tacrolimus methotrexate in the US, different form of GVHD prophylaxis, tacrolimus methotrexate and Marivorok, tacrolimus, methotrexate, bortezomib, or the PTCY with tacrolimus and NMF. And as you can see here in all the curve, the last one seems to give better result. And this is now used in a prospective trial to compare the prospectively the result with the standard GVHD prophylaxis. Prospective trial looking to in the situation of match-related and unrelated donors have been presented by Thiovan 2 years ago, showing, in fact, good results in favor of PTCY, as you can see here, with a lower incidence of acute and chronic GVHD. This paper have never been submitted to my knowledge at the present time, so we are still waiting for that. In the meantime, we have conducted in France, under the supervision of the Saint-Antoine Hospital, prospective clinical trial comparing post-transplant cyclophosphamide versus ATG after RIC PBSC transplantation for match sibling or unrelated donor, match unrelated donor. And we will have the analysis of this program at ASH. So I will conclude with this provocative question that other investigators have raised recently. Is post-transplant cyclophosphamide the new methotrexate? And in fact, their conclusion at the present time, on 2020, is the fact that there is no question concerning haplotransplant. You have to use PTCY, and I have not talked about the Chinese experience, but this Chinese experience is really devoted to a younger patient. And in the meeting in Marseille over the last 2 days, Professor Wang developed also the idea that he is now using PTCY in combination with ATG. In the situation of match-related donor, we don't know exactly, but there are no data at the present time to know if it's good to use PTCY. We have to wait for the prospective trial. In the other situation of unrelated donor, it seems to be very good. It's a good clinical option in the two situations of match unrelated donor or mismatch unrelated donor. And I would say that in our own experience in Marseille, it is our preferred strategy for mismatch unrelated donor. So on this last word, I will thank you, and I will be pleased to discuss with you at the end of the session. Thank you.
Thank you very much, Didier, for really very beautiful, very comprehensive talk. And it is quite amazing that roughly in around 10 years, post-transplant cyclophosphamide has become a sort of a Swiss knife for GVHD prophylaxis. And obviously, in your conclusion, you stated the paper showing it's a clinical option here and there, but I believe when we look to the EBMT registry, it's now being very widely used. And we'll discuss all of these issues. And I'm very grateful to all of you. We have already some very good questions, but please keep on sending your questions that I will share with the panelists. So for now, I would like to introduce Dr. Remy Dulery, who is a consultant at the Saint-Antoine Hospital. He is the head of the transplant unit in our hospital. And actually, Remy will give you an overview about the use of transplant for refractory malignancies. And, you know, when many of us trained a few years ago, speaking about transplanting refractory diseases was viewed like as something totally unbelievable or unconceivable, and you needed to be in complete remission. But now, when you look again to the registry, the number of patients receiving a transplant while being in a relapse or refractory situation is quite amazing. And we owe this not only to the advent of haplotransplant, but also to safer conditioning regimens. And this is what Remy will address. Remy, the floor is yours.
Hello, everyone. My name is Remy Dulery. I work in Paris Saint-Antoine in Sorbonne Université. I would like to thank the IACH for giving me the opportunity to do this presentation. And for the next minutes, my goal will be to give an overview of the Thiotepa-based platform for refractory hematological malignancies. These are my disclosure. Well, let's start with the clinical case. Mr. R is 54 years old. He has acute myeloblastic leukemia with intermediate karyotype. He is triple negative. He is refractory to 2 courses of induction chemotherapy, and the bone marrow aspiration shows 23% of blasts. He has a match-related donor. What would you do? Will you try a 3rd line of chemotherapy? Would you rather perform allogeneic hematopoietic cell transplantation with a myeloablative conditioning regimen or with a reduced intensity conditioning regimen? Will you use a sequential approach or will you propose palliative care? For acute myeloid leukemia patients in primary treatment failure, the chance to achieve a complete remission with the standard treatment is 10 to 20% at best. Overall survival at 1 year is less than 10%. In case of failing 1 renution attempt, the probability of complete remission is below 1%, and the new therapies such as venetoclax are not curative in this context. In the light of these poor results with conventional therapy, allogeneic transplantation is the recommended treatment. It represents the only curative option for the treatment of refractory AML patients. However, the standard myeloablative conditioning is associated with a very high overall mortality in this context, around 40% at day plus 100, thus limiting its use. Also, in the last decade, the advent of reduced intensity conditioning allowed a significant reduction of non-relapse mortality, expanding the transplant option to those patients who are ineligible for standard myeloablative conditioning. However, in refractory AML, reduced intensity conditioning may not sufficiently control the disease to allow a GVL effect to occur. These results led to the development of the so-called sequential transplant approach. I'm sure you're all familiar with the FLAMSA regimen, which combines a short intensive course of salvage chemotherapy to decrease the leukemia cell burden with a reduced intensity conditioning regimen. The use of DLI as immune therapy takes also full part of this sequential approach. The first study reporting FLAMSA included 103 patients. 1 out of 3 were in primary induction failure and 50% in relapse less than 6 months after a first complete remission. This strategy allows better disease control without increasing toxicity. 2 and 4 years after transplantation, estimated OS was 40% and 30% respectively. The respective leukemia-free survival rates were 50% and 32%. The non-relapse mortality at 2 years was 22%. The OS was significantly better in patients who received 2 courses of chemotherapy before transplant compared to those who received more than 2 courses. These latter had a 2-year OS of 22%. This observation favors an earlier timing of transplant once AML has appeared to be chemo-refractory. In addition, reinduction attempts have a high mortality rate, up to 26% in refractory patients, a fact that will also argue against several reinduction in refractory patients. Now, does the sequential conditioning approach really improve outcomes compared to myeloablative conditioning in relapsed refractory AML? Well, a registry-based analysis by the Acute Leukemia Working Party of the BNT aimed to answer this question. Eligibility criteria included age between 18 and 50 years and first transplant from a matched sibling or an unrelated donor. A total of 1,018 patients were included. These are the conclusions. One, FLAMSA with TBI and myeloablative conditioning led to similar transplant outcomes. However, FLAMSA without TBI was associated with lower non-relapse mortality, resulting in increased overall survival. There were no significant differences in terms of relapse incidence between FLAMSA and MAC. So this data suggests that FLAMSA without TBI may be a preferred conditioning regimen in patients with active refractory AML due to a lower non-relapse mortality. These results achieved with the sequential FLAMSA strategy are among the most promising published so far. However, the results are still unsatisfactory in terms of long-term leukemia control. The high incidence of severe toxicities related to enzacrine, mainly cardiotoxicity, and total body irradiation hampers the overall safety and success of the procedure. Thus, other platforms have been developed, among which clofarabine-based sequential conditioning, CETRIC, in a phase 2 prospective multi-center study, including 24 patients from 18 to 55 years old with AML in primary induction failure. The 1-year and 2-year OS were 54 and 37% respectively. The non-relapse mortality was 13%, and the 2-year progression-free survival 28%. Overall, this sequential conditioning regimen combining clofarabine and cytarabine represents a significant improvement in terms of toxicity, which a low non-relapse mortality. However, relapse remains the principal complication in these patients. An interesting data is that sequential therapy was not efficient in patients with very proliferative and active disease. In a large cohort study, it was recently confirmed that the sequential clofarabine-based regimen provides a high complete remission rate in this critical population, although relapse remains a matter of concern and 2-year outcomes are relatively poor. We developed in Paris Saint-Antoine a new sequential approach combining Thiotepa, cyclophosphamide, and etoposide, followed by the classical reduced intensity conditioning, fludarabine, and busulfan, and the use of prophylactic DLI after transplantation. This Thiotepa-based platform was also proposed in a haplo setting with post-transplant cyclophosphamide and ATG. Dose reduction was allowed for patients older than 60 years and or with comorbidities by using only 5 milligrams per kilo of Thiotepa and 3 days of cyclophosphamide and etoposide. We published in 2018 the results of this approach in patients with refractory hematological malignancies, including 51 acute leukemia patients with persistent excess of blasts or positive minimal residual disease. Other patients had acute lymphoblastic leukemia, myelodysplastic syndrome, myeloproliferative neoplasm, CMML, or lymphoma. Now, coming back to Mr. R, the match-related donor is contraindicated. You are left with 2 options, a HLMH 10 out of 10 unrelated donor or a haploidentical donor, his son. What would you do? Well, to try to answer this question, we can have a look through our study. At day plus 30, 40 patients were in complete remission. 1 had persistent leukemia and 4 had died before engraftment. The 2-year overall survival was 42% in AML patients. The 2-year progression-free survival, 38% for all patients. Acute grade 2-4 GVHD occurred in 24% of patients, chronic GVHD in 32%. The 2-year non-relapse mortality was 15% in haplo, 24% in all patients. The GRFS was significantly better in haplo than in unrelated donor. Well, these results endorse the safety and efficacy of a Thiotepa-based sequential approach in haplo with post-transplant cyclophosphamide and immunomodulation. Thus, in refractory hematological malignancies, there seems to be no benefit in searching for an unrelated donor when a haplo donor is easily and quickly available. More than half of the patients with relapsed refractory AML are older than 60 years. The question is the Thiotepa-based sequential approach feasible in patients aged over 60 years? We conducted a retrospective study in Saint-Antoine, including all consecutive patients with refractory AML and myelodysplastic syndrome who received the Thiotepa-based sequential regimen. Well, these data are still unpublished, and they will be presented in December at ASH. Patients were aged up to 76 years. 24% of patients had between 60 and 64 years. 29% of the patients were older than 65 years. 82% had AML. Patients were either in primary induction failure or in relapse after a first complete remission. Now, what is the impact of age? If you look at the non-relapse mortality, it was 15% in patients younger than 60 years and 32% in patients of 60 years and more. There was no significant difference in terms of relapse incidence. In terms of GVHD, you can see that the incidence was very low in patients older than 65 years, with 14% of acute grade 2-4 GVHD and no grade 3-4 GVHD. 6% of these patients older than 65 years had chronic GVHD. The incidence of GVHD was significantly reduced with lower dose of Thiotepa at 5 mg per kilo instead of 10 mg per kilo. In line with our previous results, there was an increased risk of GVHD with unrelated donor compared to a family donor. The results are very promising in terms of progression-free survival and overall survival. The 2-year OS was 55% in patients younger than 60 years and 48% in patients older than 60 years. If you look at patients older than 65 years, they had a 2-year progression-free survival of 37% and an impressive 2-year OS of 50%. Once again, the best outcomes in terms of progression-free survival, overall survival, and GRFS were in patients with a haplo donor. Outcomes in patients older than 60 years were better in this study than in a large multi-centric study of the acute leukemia working party of the BMT, which compared different sequential conditioning regimens in refractory AML. The OS in this multi-centric study ranged between 25 and 39% in patients older than 55 years, compared to 48% in our study in patients older than 60 years. No matter the sequential conditioning regimen you use, an important part of the sequential therapy is to enhance the GVL effect by using two levers, one, VLI, and two, low-dose maintenance chemotherapy. In standard risk AML, preemptive VLI can reduce the risk of relapse and significantly improve overall survival. In high-risk AML, I would recommend administering prophylactic VLI without waiting for the MRD to become positive. Using a FLAMSA sequential approach, you can see in this study that the 6-year PFS was 68% with prophylactic VLI compared to 38% in the control group. Enhancing the GVL effect can also be achieved with chemotherapy, as azacitidine alone following transplantation can augment expansion of regulatory T cells and induce CD8 plus T cell responses against a range of tumor antigens. The use of prophylactic low-dose azacitidine was assessed prospectively in this study. Azacitidine was given at a dose of 32 milligrams per square meter for 5 consecutive days, every 28 days. To enhance the GVL effect, prophylactic DLI was integrated with cycle of azacitidine. The cumulative incidence of GVHD was 32%. The overall and disease-free survival were 66% at 2 years, and the cumulative incidence of relapse, 28%. These results confirm that azacitidine is well tolerated as prophylactic treatment to reduce the risk of post-transplant relapse and compared favorably to those of patients who receive no post-transplant maintenance. These results were confirmed in a real-life setting in our center. Of 32 patients analyzed, 21 were treated for prophylactic use and 11 preemptively. In the prophylactic group, all patients are alive at 1 year with an event-free survival of 95%. In the preemptive group, the 1-year EFS was 54% and the 1-year overall survival, 82%. In FLT3 positive AML, we now have solid data showing the benefits of sorafenib maintenance. Recently, a double-blind phase 2 prospective trial was conducted. Patients were randomly assigned to receive 2 years of either sorafenib or placebo. The 2-year RFS was 53% with placebo versus 85% with sorafenib. Overall, sorafenib maintenance therapy reduces the risk of relapse and death after transplant for FLT3 positive AML. So, to conclude, to whom could you propose this Thiotepa-based sequential therapy? First, relapse refractory AML, either in primary induction failure or either if they relapse after a first complete remission. You can also propose it to relapse refractory ALL or lymphoma, which did not reach complete remission, or in patients with myelodysplastic or myeloproliferative neoplasm with excess of blast. A Thiotepa-based sequential platform may be safe and efficient in selected patient age of more than 65 years. How to administer sequential therapy? Well, sequential conditioning regimen allow better disease control without increasing toxicity. Finally, I would like to give some practical messages. First, sequential therapy should be proposed no later than after the second course of chemotherapy. Second, there seems to be no benefit in waiting for unrelated donor when a haplo donor is easily and quickly available in refractory disease. Third, the sequential approach should include enhanced strategies to prevent relapse after transplant, such as DLI or low-dose maintenance chemotherapy. I would like to thank all my colleagues in Saint-Antoine, the nursing staff, for doing an amazing job taking care of the patients. And I thank you all for your attention, and I will be happy to answer your questions.
Thank you very much, Remy, for really a nice and very elegant talk, but also I think our audience really appreciate the practical advice, and it is quite amazing actually. Professor Blaise described a series of patients above age 70. You are now telling us the feasibility and safety of transplant in refractory disease above age 65. These are really the most challenging situations, but definitely I'm convinced that these results will continue to improve thanks to novel conditioning regimen. And I think treosulfan is now the superstar in the field. And this is the reason why it is my great pleasure to welcome Professor Arnon Nagler, who is, I think, one of the top investigators worldwide who have the largest experience with the use of treosulfan actually for conditioning, and definitely this drug is improving the outcome of patient, whether used in remission or in refractory disease. So Arnon, thank you for joining, and the floor is yours. Thank you very much.
Hi everybody, it's a big honor for me to participate in a special web conference on behalf of the International Academy of Clinical Hematology on the topic of alkylating agent, all dogs with new tricks, and my trick is treosulfan. So the official title of my talk is the novel Treosulfan-based platform for conditioning focusing on AML and MDS. And I'm Arnon Nagler from the Chaim Shiba Medical Center, Tel HaShomer, and Vice Chair of the Acute Leukemia Working Party of the EBMT, and I have no disclosure for this presentation. So we all know that allogeneic stem cell transplantation is a potentially curative therapy for patients with acute leukemia and myelodysplastic syndrome. But so far, there is no proven survival advantage for any conditioning regimen over the others. Prior studies have shown that reduced intensity conditioning is associated with lower non-relapse mortality compared with myeloablative conditioning. However, relapse rates are increased, resulting in similar survival. And therefore, novel regimen that will reduce transplant-related toxicity while retaining maximal anti-leukemic effect will be of benefit. And fludarabine combined with treosulfan has been shown to be reduced toxicity regimen with intense anti-leukemia activity and limited toxicity in patients with myeloid malignancies, and I will try to convince you in my talk in this statement. So if we discuss treosulfan or treosulfan-based reduced toxicity regimen, the search continues for novel conditioning regimen that will reduce transplant-related toxicity while retaining maximal anti-leukemic effect. Treosulfan or dihydroxybusulfan is a prodrug of bifunctional alkylating cytotoxic agent. It targets both the primitive and committed hematopoietic stem cell and also has immunosuppressive properties. Toxicity profile looks encouraging, with the dose-limiting factors being mucositis, diarrhea, and skin toxicity, and therefore treosulfan is a good candidate to be introduced in the preparative regimen of transplantation, and previous studies demonstrate the feasibility of this regimen. So our first study compared fludarabine treosulfan to fludarabine 2 days of busulfan and fludarabine 4 days of busulfan in AML and MDS. We had for this study 256 patients. Out of them, 208 were AML and 68 were MDS. 85 of them received fludarabine treosulfan, 106 fludarabine and 2 days of busulfan, so reduced intensity conditioning, and 84 fludarabine and 4 days of busulfan, so myeloablative conditioning. Toxicity, as for toxicity, we have seen more mucositis with the myeloablative doses of busulfan, so fludarabine and 4 days of busulfan. There were more infection with the fludarabine treosulfan, but the 5-year overall survival for advanced disease was better for fludarabine treosulfan and fludarabine 4 days of busulfan. And in multivariate analysis, fludarabine treosulfan was associated with lower relapse rate with hazard ratio of 0.6 and p-value of 0.03. So if we look on the curves for the whole population, the 5-year non-relapse mortality was 29% for the fludarabine treosulfan, 20% for the fludarabine 2 days of busulfan, and 18% for the fludarabine and 4 days of busulfan. No difference. If we look on the relapse, 5-year relapse rate, it was 36% with fludarabine treosulfan, 47% with the fludarabine and 2 days of busulfan, and 40% with the fludarabine with 4 days of busulfan. In what we call at that time, because this was published in 2012, early intermediate AML, the 5-year overall survival was no difference between fludarabine treosulfan, it was 46%, fludarabine and 2 days busulfan 44%, and 50% with the fludarabine 4 days of busulfan, not significant. But in advanced AML, so active disease, the overall survival at 5 years were better with fludarabine treosulfan 33% and fludarabine 4 days of busulfan 28%, myeloablative doses, while with the reduced intensity protocols, 2 days of busulfan, it was only 9%, and this was significant. And also, interestingly, there was lower incidence of acute GVHD with fludarabine treosulfan. So we moved to the data set of the acute leukemia working party, and we analyzed 520 AML patients with long-term follow-up after treosulfan-based conditioning. And what we found is that in patients, the results are similar to other similar studies, and that patient in CR has better overall survival and leukemia-free survival compared to the other disease status. And the conclusion of this large set of patients, actually at that time, the highest number of the biggest cohort with treosulfan-based conditioning, was that treosulfan appears to be promising candidate drug to be used for conditioning prior to allogeneic transplantation for AML with good engraftment, acceptable rate of non-relapse mortality, GVHD, and overall survival and leukemia survival. The outcome appears to be comparable to other series using different alkylating agents. The disease status at transplant remained a major predictor of outcome. But when we tried in those patients that received, besides the fludarabine treosulfan, melphalan, or Ara-C to intensify the conditioning, especially with patients with active disease or high-risk AML, the combination led to higher toxicity and therefore no obvious benefit, and therefore should be avoided. Then we did a very big study comparing again treosulfan versus busulfan in hematopoietic stem cell transplantation in AML, again in the acute leukemia working party. For this study, we have 1,265 patients that were conditioned with fludarabine and 4 days of busulfan, so myeloablative doses. 1,456 patients conditioned with fludarabine 2 days of busulfan, so reduced intensity conditioning. And then 2 doses of treosulfan, the 14 gram 3 days, and the 12 gram 3 days, 2 meters square. So FT 14, 503 patients, and FT 12, 168 patients. If you look on the curves for patients in complete remission, there is no difference in these four regimens, and busulfan in 2 doses and treosulfan in 2 doses as for relapse, non-relapse mortality, leukemia-free survival, and overall survival. But in patients with active disease, again, we see that with fludarabine treosulfan, we have lower relapse rate and higher leukemia-free survival and overall survival, while non-relapse mortality is not different. So the highlight for this big cohort of patients was that outcome after stem cell transplantation for AML is similar after various conditioning regimens. The treosulfan conditioning is more similar to myeloablative conditioning than to reduced intensity conditioning. The treosulfan can be administered safely in older patients with lower rates of GVHD. I will show you in a minute the multivariant analysis. And treosulfan conditioning possibly provide better outcome in active leukemia. And so in multivariant analysis, the poor prognostic factor for survival were advanced age and advanced disease status, a secondary ML. The poor prognostic factor for relapse or higher relapse rate was noticed with the reduced intensity doses of busulfan, for fludarabine 2 days of busulfan, advanced age, advanced disease, secondary ML, and interesting sibling donor, so higher GVL in unrelated donor. Non-relapse mortality was the lower with fludarabine and treosulfan as a dose of 12 gram meter square times 3. And it was more higher in advanced age, advanced disease status, and unrelated donor. And treosulfan-based regimens were associated with lower rate of GVHD. So for grade 2 to lower rate of grade 2 to 4 GVHD was with the 14 gram dose with hazard ratio of 0.76 and p-value below 0.005. And for the 12 gram dose, hazard ratio 0.063 and p-value below 0.009. And also lower incidence of chronic GVHD at the 12 gram dose with hazard ratio of 0.65 and p-value of 0.01. And for the 2-year overall survival in active disease, so treosulfan was the best, better with the highest dose of 14 gram, better than 4 days of busulfan, and has a ratio of 0.06 and a p-value of 0.008. But the pivotal study was published in Lancet Hematology last year. This was the phase 3 study, 2-arm, in which they compared fludarabine and treosulfan, this time 10 gram per meter square, time 3 days, to the busulfan at 3.2 milligram per kilogram per day, time 2 days, so 2 days of busulfan in combination with fludarabine. You can see here the regimen with ATG Fresenius for unrelated donors. So eligible criteria were patients with AML or MDS age 50 to 70 with a comorbidity score, SORO score HCT-CI of above 2, Karnofsky score above 60, so patients that are not the best one, AML equal or more than CR1 or MDS, and the donor were sibling donor or 9 out of 10 or 10 out of 10 unrelated donor. And the result of this comparison was that the 2-year event-free survival was 64% with treosulfan and 50% with 2 days of busulfan, with HR hazard ratio of 0.65, and this is the very significant p-value. That the 2-year overall survival was 72.5% with treosulfan versus 56.4% with fludarabine 2 days of busulfan with hazard ratio of 0.64 and this p-value. And this was due to lower 2-year transplant-related mortality here in blue or light blue with treosulfan compared to the 2 days of busulfan and fludarabine in red. So it was 12% with treosulfan versus 20% with 2 days of busulfan, HR of hazard ratio of 0.63 and a P of 0.034. And there was no difference in the relapse rate, so it was 22 with treosulfan versus 25.2 with 2 days of busulfan, with fludarabine with hazard ratio of 0.82 and non-significant, p 0.26. As for GVHD, we can see here that there was somewhat lower acute GVHD 1 to 4 with the treosulfan in blue, but this is not significant. Similar grade 3 to 4 acute GVHD. Similar overall chronic GVHD, which was high, 60%. But extensive chronic GVHD, there is a trend for lower extensive chronic GVHD with treosulfan in blue with p-value of 0.075, not significant. So the official conclusion of the study, because this was non-inferiority study, that event-free survival at 24 months after transplant was significantly non-inferior with treosulfan, that the 2-year overall survival was significantly superior for patients treated with the treosulfan as compared to the busulfan, again 72 compared to 56, that the estimated 2-year event-free survival and overall survival were consistent within relevant prognostic subgroups, and the treosulfan regimen significantly reduced the 2-year transplant-related mortality. So we also compared the FLAMSA, which is very attractive protocol, and more and more patients are getting FLAMSA protocol. So the reduced intensity FLAMSA with fludarabine treosulfan in 629 patients with AML. So out of this cohort, 281 received fludarabine treosulfan, 203 received FLAMSA and the TBI, the original FLAMSA, and 145 received FLAMSA and busulfan. So the disease-related outcome of the patient that condition with the various protocols are illustrated in these graphs. So this is non-relapse mortality, the relapse rate, the leukemia-free survival, and the overall survival. And you can see here that the relapse rate was lower and the leukemia-free survival was higher with the FLAMSA, with the TBI here in a dash. But this was with higher incidence of acute GVHD. We also compared TBF, very popular protocol, to fludarabine treosulfan and the FLAMSA, and this time in relapsed refractory AML. So for this study, we have 856 patients, 113 received the fludarabine treosulfan, 112 TBF, and 631 FLAMSA. 42 were transplanted from sibling donor, 41% for 10 out of 10 unrelated, and 17 from 9 out of 10. And you can see on the curves, there was no difference between the various protocols. So if we look on the relapse rate, it was 46 with fludarabine treosulfan, 54% with the TBF, and 53 for FLAMSA. Non-relapse mortality, also similar, 26 with treosulfan, 24 with TBF, and 20 with FLAMSA. Leukemia-free survival was about 29 with treosulfan, 22% TBF, and 27 with plasma. 2-year overall survival was 37 treosulfan, 24 TBF, and 34 plasma. And the composite endpoint, no GVHD and no relapse, so GVHD relapse-free survival was 23 with fludarabine treosulfan, 13 with TBF, and 20 with FLAMSA. But remind you, this is relapse refractory AML. More recently, we compared treosulfan-based regimen to reduced intensity conditioning and myeloablative conditioning in patients with MDS. So we had 367 patients with fludarabine treosulfan, 687 with reduced intensity, and 668 with myeloablative. You can see here that the patients with myeloablative protocols were younger, they had less unrelated donors, they had more bone marrow graft, but there was no difference in the disease status in prior transformation to AML. As for status at transplantation, in the Treosulfan, we have somewhat lower chemorefractory disease compared to the others. Time from diagnosis to transplant was a bit longer in the reduced intensity protocol. So at the end, overall, there was 1,722 patients, and you can see for non-relapse mortality that it was lower with the was higher with the myeloablative conditioning and lower with the reduced intensity conditioning, but the fludarabine treosulfan here is close to the reduced intensity. So you can see here the multivariant analysis. So treosulfan is with toxicity similar to reduced intensity conditioning. And as for the relapse rate, it was higher with the reduced intensity, lower with fludarabine with myeloablative, and similar to fludarabine treosulfan. And you can see here the multivariant analysis. So treosulfan is with a strong anti-leukemia effect like myeloablative conditioning and lower non-relapse mortality similar to the reduced intensity conditioning. You can see here other prognostic factors like age and unrelated donor and earlier years of transplant. So overall for these studies, the 5-year non-relapse mortality for the entire group was 35%, and the 5-year relapse rate for the entire group was 21%. So with a median follow-up of 20 months up to 171 months, we have a big bias. We had 807 patients that are alive and 900 patients that are died. Out of the deaths was 328 from relapse and 587 from the non-relapse mortality. So the 4-year overall survival is 44%. You can see here the overall survival, which is the best with fludarabine, better than reduced intensity and myeloablative, and you can see here the multivariant analysis. So the conclusion is that fludarabine treosulfan conditioning is associated with similar low relapse rate as myeloablative and similar low non-relapse mortality as reduced intensity. This results in improved outcome over both reduced intensity and myeloablative, and fludarabine treosulfan might be the preferred regimen in MDS. Of course, we need 2-arm study. What about toxicity? So in this study in 115 patients, we can see that the toxicity for mucositis is lower with fludarabine treosulfan compared to the fludarabine 4 days of busulfan. You can see here that the mucositis is lower with reduced intensity conditioning and reducing toxicity conditioning. And so for myeloablative conditioning, we had 39% mucositis compared to 34% and 27% with reduced toxicity. So this is the fludarabine treosulfan. The overall, the mucositis grade 2 to 4, so moderate to severe, it was in 60% of the patient, and the mucositis risk was the lowest with fludarabine treosulfan, the reduced toxicity regimen with odd ratio of 0.05 and p-value of 0.001. So we did a bigger study for the comorbidities and non-relapse mortality with the various conditioning that we are using, and you can see here the group, the fludarabine treosulfan, for my talk today, 271 patients, age 61.2. We can see here the Karnofsky score, 82% were above 90. The HCT-CI score, 43% was above 3, the year of transplant. The disease risk, 43 were early. AML, disease risk index, 18% were intermediate, and 39 were advanced. And the GVHD prophylaxis, the donor, and the CMV status. And here is the list of comorbidities in this population, with the highest one in mild hepatic, then hypertension, obesity, and pulmonary. And if we look on the comorbidities, it was conditioning associated. So the cardiac toxicity was higher in the fludarabine busulfan protocol, as you can see here, while pulmonary toxicity was higher with fludarabine melphalan, and for the infection rate was higher in the fludarabine treosulfan, and you can see here the plots. And if we look now at the graph, so for patients with cardiac morbidity, the cumulative incidence of toxicity, you can see the fludarabine busulfan, the difference. For the infection, negative and positive, the non-relapse mortality if you have infection or not for fludarabine treosulfan, and for the pulmonary toxicity, the non-relapse mortality, yes or no, with fludarabine melphalan. And if we look on the same principle in the acute leukemia working party data set, so 300, this time 3,000, so a much huge, bigger cohort, 3,338 patients. Cardiac toxicity was defined as decreased left ventricular ejection fraction, history of coronary artery disease, pulmonary as FEV1 or DLCO below 65, and diabetes required treatment. You can see here the demographic of the patient and also number of the patient in fludarabine treosulfan for my current talk. And you can see that the cardiac comorbidity was again higher with the fludarabine busulfan, and infection were higher with the fludarabine treosulfan. And if we look on the plots, you can see that yes or no cardiac disease make no difference in the fludarabine treosulfan, but made a huge difference in the fludarabine busulfan. So the last study or piece of information, in interesting one, need to be confirmed that we have shown that missing HLA-C group is associated with lower relapse rate and better survival in AML-MDS patient transplanted with fludarabine treosulfan. So for this study, we had 203 patients, median age was 58, 97 were sibling donor and 106 unrelated donor. Follow-up was 4 years. So as for Kirley grant, group 1 allele is C1, group 2 allele is C2 and C2. So from this patient, we had 34 patients C1, 19 C2, and 48 C1, The 4 years overall relapse rate was 38%, non-relapse mortality 27%, and leukemia-free survival 36%. Relapse in CI and in the C1 patient was 43%, was 45% in C1, and was the lowest in C2, 26%. And in multivariant analysis, relapse in the C2 patient was the lowest with hazard ratio of 0.4 and the p-value of 0.04 significant. And leukemia-free survival was the best in patients with the C2, so it was 46% compared to 33 in the C1 and 30 in C1, and in multivariant analysis, again, leukemia-free survival was the highest in the C2 with hazard ratio of 0.6 and p-value of 0.06, and you can see here the curves for leukemia-free survival. It was the best for the C2, and the relapse incident was the lowest with the C2, and no difference. So missing HLA-C group 1 is associated with lower relapse rate in the treosulfan, and we are further exploring this interesting finding. So to conclude, alkylating agent, all dogs with new tricks for the treosulfan-based platform. Treosulfan, the hydroxybusulfan, is a prodrug of a functional alkylating cytotoxic agent. The target was primitive and committed hematopoietic cell and have good nice immunosuppressive properties. Fludarabine treosulfan is a reduced toxicity regimen with intense anti-leukemia activity and limited toxicity in patients with myeloid malignancies. It's associated with decreased risk of organ toxicity but higher infection rate. In a phase 3 study, it was shown that compare fludarabine and 2 days of busulfan compared to fludarabine treosulfan at 10 gram per meter square, total 30 gram per meter square, demonstrated lower TRM and better overall survival with fludarabine treosulfan. And the optimal conditioning pre-transplant in AML should be tailored in according to the disease status and patient and specific organ comorbidities. And thank you, and I will be happy to take questions. Thank you very much.
Thank you very much, Professor Nagler, for a very, very nice talk, but also you did a very comprehensive overview of the history of treosulfan in conditioning, which has been ongoing actually since almost 15 years. And it is very impressive to see the development of this drug. And by the way, I would like to thank our audience for really sending dozens of questions. This is quite amazing. And actually, guys, I realized that you don't need to organize webinars about CAR T cells to attract the audience. You can speak about all the alkylating agents and have hundreds of people being connected. So let me invite the panel. I know we are running a little bit late, but we'll take 10 to 15 minutes actually for discussion, if you don't mind, guys. We have received a lot of questions. Actually, I took the opportunity to reply to some of them by writing because the answer was relatively easy for me, but I'll share with you some other questions because what Professor Nagler presented could show maybe that with treosulfan, for instance, we have the efficacy of a sort of a myeloablative drug, but then the safety or the lower toxicity compared to reduced intensity. So maybe there is a sort of a partnership here to envision with other combinations. So I have a first question, and maybe each member of the panelists can address this. Why not actually combining Thiotepa and treosulfan and fludarabine, for instance? And we have a couple of questions about myelofibrosis. So I don't know who wants to start on this. Maybe Remy, because you discuss the issue of Thiotepa, and then I'll move to the other panelists.
Yeah, I think it's a very, very interesting question, and actually it's something we're considering because we have, as I've shown you, good results with a Thiotepa-based platform. Thiotepa allows engraftment in most patients, especially patients with myelofibrosis. And we still have problem with toxicity. As I've shown, it can go up to 30% in very fragile patients. So one possibility will be to keep the same sequence as I've shown with Thiotepa, cyclophosphamide, etoposide, and for the reduced intensity regimen, why not replacing the busulfan by the treosulfan? That will be interesting to evaluate in patients in a clinical trial.
So, Professor Nagler, what do you think about actually, let's wider a little bit the question beyond myelofibrosis and use, what would be your, we have a couple of questions about this for a young fit patient but refractory AML. What would be your optimal combination when it comes to the sequential or Flamza-like regimens? And then I'll direct the same question to Didier.
So, I mean, this is an option in a young patient that have resistant or refractory or relapsed disease. There were some studies that combined these two drugs, for instance, for Milano, for haploidentical transplant, and some other studies. We need to be careful because when we analyze the data of treosulfan plus RC or cyclophosphamide, the results were not improved. Toxicity went higher. So I think that, but in young patients that can tolerate two alkylating drugs, and we are looking on this data now in the acute leukemia working party, as you know, I think that this is an option. We need to be careful from the toxicity and to see that this is a good combination of two drugs.
Didier, what do you think?
I think the idea is appealing and intriguing, but I would say as Arnon said, and as a older dog, I will be cautious with what we do. The idea of the Flamza regimen, basically to split the intensity of the conditioning regimen on a longer period of time, and that's very important. And on this basis, you can be imaginative because, in fact, at the end of the day, as stated by Remy previously, the patient with refractory leukemia have no chance of anything. So you have still to push the innovation. And as you said, that many people are connected at the present time, it's still something where we have to work on. And the innovation is needed in this situation. And all ideas could be good, but we have to be careful. It's transplantation. Each time we modify something, we may change the outcome of the transplantation.
Thank you, Didier. So let me stay with you, Didier. We have a question here, and the several people in the audience thanked you for a really beautiful talk about post-Cy. So I'll put all questions together. Do you think that post-Cy can be now used standard of care for GVHD prophylaxis, irrespective of the donor type? Very provocative question.
But I could give a provocative answer. I would say yes, but it's not enough. As you know, it's still we have still GVHD in a large proportion of patients. So we have still to improve the way to do. And I was not very against, but I was not in favor of combining the approach with PTCY and ATG, and I changed my mind on that because results are interesting on this way. I don't know what is the optimal way to do that. Pre-transplant, post-transplant, low dose, higher dose, I don't know, but still we have a possibility to improve the outcome. But it shows that PTCY will not be only on selected haplo-transplant patient.
Excellent. So we have another question about post-Cy, and maybe I can answer it quickly. This is about whether we can use post-Cy in the pediatric population. Obviously, none of us on this panel are pediatrician. However, I'm well aware of a very recent publication, like maybe 1 month or 2 months ago, in bone marrow transplantation from the Pediatric Working Party of the Brazilian Society of Hematology and Transplantation. These are, I think these were more than 100 patients, showing very nicely that post-Cy can be applied in a pediatric population for GVHD prophylaxis. So I hope, Dr. Fosdal, we have answered your question, and I refer you to this paper.
If I may make a comment on that, we have to be careful with the pharmacokinetic and the metabolism of these alkylating agents in pediatrics. And I do think it's not exactly the same thing. And because pediatrics are less experienced because they don't use haplo as we do in adult patients, it's a reason why we don't know yet exactly to do. But the Brazilian report was interesting.
Well, because you mentioned pharmacokinetics, we have a question. Maybe Arnon, you can take it. Can we perform pharmacokinetics of treosulfan like busulfan? And where do you see this? I don't think it has been done in the randomized registration trial.
So you know, I could not put everything. It was long enough, but we did. There is a way to do pharmacokinetics of treosulfan. First of all, it was done in animal models in Germany and also in Poland, but we did it in collaboration with the state by red blood cell membrane. So there is a way, I'm not pharmacologic, to evaluate the pharmacokinetic of treosulfan in red blood cell membranes, and we did it in the past and also report it, and we also pursue it in our studies. It's not so easy, but it's possible, and there is a way to do it, and I think it will be important, like in all other alkylating agents, especially like Professor Anderson and Didi Blaise, have shown us, and also in their talk in the last meeting in Marseille. So yes, I'm fully for that.
Okay, thank you very much, Arnon. Maybe one question to you, Remy, and this is from Dr. Andreas Susenka, who is a very loyal supporter of the IACH. Hello, Andreas. And the question, so he has several questions. I'll take only one for the sake of time, is about the timing of using cyclosporin or tacrolimus in the post-Cy setting. The original publications from Hopkins were about day +5. But I think you can use it earlier. Can you comment on this?
Yeah, thank you for the good question. Actually, it was published by other teams in Geneva, for instance, and also it's our experience in Saint-Antoine to use cyclosporin earlier. In our center, we use it at day -3, and we are running analysis to compare -3 compared to day +5. Well, there is no clear answer now. We have to go further in our analysis, but it's really an option to start it earlier.
So there's no contraindication if you want to start it earlier. There's no harm if your standard of care is to do it like this. You don't need to change the whole organization of the way you administer tacrolimus or cyclosporin in your transplant program. Here, maybe I'll go back to Didier, and both the other two panels can also comment. So we have different questions about the choice of donor, and this is, I think, has been triggered by the conclusion of Remy saying, well, if the results of haplo are likely, because it wasn't a randomized trial, likely the best compared to MUD, well, we should just, in refractory patient, go to a haplo donor whenever available. Do you share such conclusion, or if you have a choice between an unrelated donor 10 out of 10 and a haplo donor in a refractory AML, would you go for the haplo, or you would still go to a 10 out of 10 unrelated donor? Arnon.
So the data on haplo, are intriguing, but we are still doing 10 out of 10. We have not seen lower, in all the studies, the acute leukemia working party, which is registry-based, and other study, I just reviewed it recently. We have not seen lower relapse rate in haploidentical transplant in acute leukemia compared to 10 out of 10 unrelated, and in our hands, results of 10 of 10 unrelated are better. Yes, I believe there is a stronger GVL effect with the haplo. This must be because of the HLA disparity, but also we have the HLA loss phenomenon that is high in haplo compared to unrelated. And therefore, at the end of the day, relapse is the same. And I would still do unrelated 10 out of 10 and not haplo, but I understand that by improving maybe the haplo and reducing toxicity, we should, like we do in Hodgkin, we should get better results at the end of the day with haplo in active disease, but till now, I have not seen data for it.
Okay, Didier, I'm sure you will have maybe a different perspective.
Yeah, it's complicated, but we have now many data, and I remember that Professor Wang last weekend in Marseille presented interesting data showing that haplo transplant was better over matched sibling donor transplant. in MRD positive patients. So you can conclude that in a more advanced disease, it could be of interest. However, transplant is transplant. When you have a 35 patient with refractory disease, is it better to have a much unrelated donor of 20, 25, or a haplodonor which could be his mother? Because we know results with his mother could be worse. So we cannot only choose a donor according to the disease. We have to choose a donor with other parameters to have the best transplantation we can have. And of course, what is very important is to have the donor at the time we need to do the transplant. So I'm sure that in the future, we will have perhaps computerized algorithm with many parameters in order to find the best donor. But at the end of the day, in the consultation, we will have to decide with the patient.
Thank you, Didier. I think this has been really a lovely conclusion, because at the end of the day, actually, this is about personalized medicine, and stem cell transplantation, allogenic stem cell transplantation, has been always leading the way on personalized medicine, because just think about choosing the donor. It's the first step of personalized medicine, which you don't have in any other field. And now, as you said, we can refine it by the age of the donor, by the relationship with parents, sons, children, brothers and sisters, etc. But it's also about refining whether it's day 0, day +5, you give cyclosporin. And now the good news we have is that we have Post-Cy, which is proving to be really an impressive tool to control or to prevent GVHD. But still, I think, Didier, you showed us very nice data that we can fine-tune the dosage of Post-Cy to further improve its efficacy and safety. And last but not least, I think after when we trained, I think at least we are 3 here to have been trained at an era where we've been told the conditioning regimen is Bucy or Cy-TBI. But now it is very amazing to see the broader choice of conditioning regimen, and probably at the end of the day, one size will not fit all. And this is why we are very fortunate having these new options now coming into the field, like Treosulfan being approved, I think, for conditioning, whereas Thiotepa is also approved, whereas historically, cyclophosphamide was never approved, and originally busulfan, oral busulfan, wasn't approved. It's IV busulfan which was approved. So guys, I do apologize, we'll not be able to take more questions. We're already running late, but I hope that you have enjoyed this educational activity brought to you by the International Academy for Clinical Hematology. It has been a true pleasure to be with you tonight. And as usual, all the educational activities of the IACH are available, open to everybody on the IACH website, clinical-hematology.org. So please do not hesitate to watch this broadcast again, or share the link or whatever the website with your colleagues and your friends. But so thank you very much, Didier. Thank you very much, Arnon. Thank you very much, Remy, for dedicating time for this web conference tonight. And I hope that we will be able to see each other very soon. And wherever you are, please stay safe and keep well. Thank you very much, and see you soon in another IACH activity. Thank you.
Thank you, Mohamad. Have a good day, all of you. A good night.
Bye-bye.
Bye.
Thank you.